हाँ तो मंडे को उनका कॉन्टैक्ट था तो मंडे को आपका भी उनसे कॉन्टैक्ट है, तो अब 7 डेज हो गए हैं, तो आप जो है आप टेस्ट करा लीजिए। तो हाँ कॉन्टैक्ट के 7 डेज या फिर अगर कुछ सिम्टम हो जाए तो, आपको कोई सिम्टम नहीं है, हाँ तो विच एवर इज अर्लियर, तो 7 डेज तो हो ही गया, तो आप करा लीजिए, आप करा लीजिए, क्योंकि आपका जो पेशेंट ये जो है इनसे कांटेक्ट जो है 7 दिन तो हो गया। हाँ एक बार आप करा लीजिए, आप करा लीजिए, हाँ आपने आप करा लीजिए, और आपके लोग जो जो इनके कांटेक्ट में है वो करा लें जी, वो करा लीजिए। और कोई अगर कोई ज़्यादा दिक्कत हो मुझे एनी टाइम मुझे कॉल कर लीजिएगा, एनी टाइम 24 आवर्स। जी जी मैडम जी। हाँ नहीं आप तो नहीं, आप तो ले आइए, आप तो ले आइए, हाँ ऐसा कुछ नहीं है। हाँ हाँ जाके ले आइए, अपना प्रोटेक्शन कर लीजिए, मतलब मास्क लगाइए और लेके आइए, तो आप मत बोलिए। हाँ बिल्कुल बिल्कुल जी जी जी। ओके मैडम, ओके, नमस्कार नमस्कार नमस्कार। मेरा ये करना भाई, इसको लगाना है। हाँ जी
स्लाइड ओपन करना सर, चालू है।
चालू है। एक वो क्लास ख़त्म हो गई, वो क्लास किसकी थी पहले LT1 में?
सर द्विवेदी सर थे।
हैं?
द्विवेदी सर थे।
अच्छा, तो लेकिन उन्होंने लिया है डॉक्टर, वो क्लास ख़त्म हो गई। देखो जब
मैं 2:45 बजे आया था, जब उस टाइम चालू था सर।
कहाँ पर? तो उस LT1 में। हाँ यहाँ लिखना पड़ेगा नाम वाम। क्या तारीख है आज? 13। चालू है ये? जी ओके, शुरू करें, अब टाइम है। हाँ
2 घंटे।
आपको यही रहना क्योंकि क्वेश्चन पूछने के लिए मुझे पता नहीं क्वेश्चन कहाँ से देखना है। अब चले गए थे तो पता नहीं चला मुझे कैसे देखना क्वेश्चन, कहाँ से क्वेश्चन देखना है। ये तो आप इधर ही रहना है कहीं?
मैं LT1 में ही रहता हूँ सर।
नहीं तो क्वेश्चन कहाँ से देखना है मुझे बता दो, मैं देख लूँगा। इसको ढक दो अभी।
वो इधर पूछते हैं सर, यहाँ पे इधर पूछते हैं इसमें।
ओके तो मैं देख नहीं पाता हूँ कहाँ पे क्वेश्चंस हैं।
इसमें
तो ऐसा करना, आप ऐसा करना, आप करीब आप 3:45 बजे आ जाना। ठीक है, ठीक है नहीं, 3:45 आप आ जाना।
इसमें दिखा दिया था। आज तो सर कमी थे क्योंकि LT1 में भी गया ना बीच वाले के पास, तो उसमें भी 3-4 ही दिखा रहे थे।
3-4
चार लोग आ गए थे।
कितने हो गए?
4 दिखा रहे थे।
Good afternoon. So let us start the session today. Today's topic is statistical methods in diagnostic test studies. So let us go through this. Look at this. appearance to the mind are of four kinds. Anything that you see, there are four possibilities, right? And of the four possibilities, only one is true, right? So what are the four possibilities? Things either are what they appear to be, that means true positive, right? Or they neither are nor appear to be, that means true negative. That means if there is something and you are seeing that, that is true positive. Something which is not there, you are not seeing, that is true negative. But other two are problematic, and other two are they are and do not appear to be. That means you have missed it, it is there but you have not been able to identify. That is what is false negative, right? And the other one is it's not there but presentation is such that you have made wrong decision, that is false positive. So any situation where you have to take a decision, these are the four possibilities, and out of these four possibilities you have to take a correct decision. Now this is not something new, this is as old as 2nd century. So this is what is the basis for diagnostic tests. Diagnostic tests, when the patient comes to you, he would come to you with lot of symptoms, many times limited symptoms, many times overlapping symptoms, incomplete symptoms, and you have to take a decision whether the person has disease or he does not have the disease, or he has a particular condition present or condition not present. So whenever you have to take a decision, you are in this kind of situation, four possibilities, and you have to take one decision. So today we are going to discuss about diagnostic tests. So the principles of diagnostic tests and prognostic tests are more or less the same. Diagnostic test is basically you want to predict a particular condition or a particular disease. So when a person comes to you, using the tool you want to say whether the person has that condition present or not. Prognostic is condition is already there, disease is already there, you want to predict the outcome. So that is what is prognostic. So principles are more or less the same. So the topic is diagnostic test. So we'll talk about diagnostic tests. And to take a decision, it has to be done based on the measurements, based on the data, right? And the clinical measurements, they are basically either nominal or ordinal, that is basically categorical, or it is quantitative. So the clinical measurements that one takes is basically qualitative or quantitative. It could be nominal, it could be ordinal, it could be quantitative, but regardless of whatever is the clinical measurement, whatever is the form of clinical measurements, at the end, to take a decision you have to dichotomize, you have to say either yes or no. Even if there is a measurement which is quantitative, so you have to dichotomize that at what cutoff value I should say that the person is diseased and the person is not diseased. So your decision is always dichotomous, whereas the measurements may be categorical, may be binary, may be more than two categories, or it may be quantitative, but your decision has to be always dichotomous, either yes or no. Establishing a diagnosis is a basically imperfect process, is a probability that rather than a certainty. Whenever you make a diagnosis, it's basically in terms of probability, not in terms of certainty. You always say that the probability of this person having this disease is 90%. So this is basically imperfect process. Diagnosis is nothing but synthesis of input, and synthesis many times for many conditions, just based on history one can arrive at a diagnosis, but in other situations history alone is not sufficient for the person, for the clinician to make a diagnosis. So in addition to history, he would also take physical measurements. Many times history and physical measurements are not sufficient, then he may go for biochemical assessment.
and then he would combine the three and would like to take a decision, or maybe in some situation even these three are not good enough for the person to take a decision, so he may use radiological tests available. Also even these four may not be good enough, so then you go for microbiological samples, right? So basically diagnosis is nothing but synthesis of inputs, and these are the various inputs, and it depends in which situation which of these you combine. Each of these they have their own advantages and disadvantages. You don't start with microbiological tests, you always start with a simple one, and as you proceed you go on proceeding further and doing more complicated tests. History is very easy to take and there is no cost involved and it's very rapid, but history is not so easy. Though they say history taking is easy, but history taking is an art. Many a times by taking history you can arrive at a diagnosis. By taking history, what you are doing is you are basically defining pre-test probability. That is what we will be discussing. So history taking is an art, it is not so easy, right? The two doctors, a junior doctor and one experienced doctor, both will take history not in the same way. For a junior doctor, based on history he may not be able to take a decision, so he may use some other test and combine the test result with history to arrive at a diagnosis, whereas an experienced doctor, just by looking at the history, taking smart history in a smart way, may be in a position to arrive at the same diagnosis, right? So history is actually take art, no cost involved, and it is quick. Physical examination, you require skill, not only skill, you require tools. Even though you have, if you want to measure somebody's blood pressure, even though the equipment is there, but how to use it, there are some SOPs for every equipment that you need to follow. Cheap in the sense you don't incur cost, there is no recurring cost. Once you buy an instrument, it will last for quite some time, and it is rapid, immediately you get the reading. Biochemical is a specialized test, not anyone and everyone can do biochemical tests. You need labs, you need those kinds of setups, you need quality control, so it's expensive. And also all biochemical results, it takes time, you don't get the result immediately. Radiological, again very specialized, very expensive, and of course it takes time. Microbiological, again specialized. So these, as you proceed further, test becomes more and more complicated. We are always in search of new tests which can be done without, let's say, microbiological examination or without radiological examination. So we are always looking for new tests which can do the job as well as an established one. So that's what is whole game about diagnostic tests. This is what is a picture that you have seen. Any research question, you have a target population, but you don't study everybody in the target population, you only study a sample of that. So in case of diagnostic test, your target population is the one where you would apply this test, you would administer this test if this test is found eventually good. So your target population for diagnostic test is a suspected population. You will never apply a test in healthy population. You will always apply a test in suspected population to discriminate disease from no disease, condition present and versus condition absent. So for diagnostic test, your population is suspected population. You take a sample and you find out what are the characteristics of the test, and then same characteristics you find out how well the test performs in your sample, and then you extrapolate that if you administer this test in population, this is what would be the kind of performance of the test. And to do that, we use statistical inference. Like any study, any kind of study, not just diagnostic test, any study, our question is for the population. We have a sample, we collect data on sample, we summarize that, and that whatever we have summarized, that we extrapolate to target population. Same thing we do for diagnostic test studies also. But in statistical inference, we have two parts. One is estimation, second is hypothesis testing. for diagnostic test, it is basically, it's not a hypothesis testing situation, it's an estimation. It's an estimation, it's not a hypothesis testing situation. Hypothesis testing situation would be when you are comparing two tests with some reference. Otherwise, it's a basically estimation. So diagnostic test studies are not hypothesis testing situation. Not hypothesis testing situation means you will not have p-value, you will only have the precision. We have discussed this earlier. So this is not a hypothesis testing situation. So what you do, what is the question of interest to us? We would like to know how well does the test identify patients with a disease. So basically there are two population, one is the disease population and second is non-disease population. So we would like to know how well my test performs among disease and how well my test performs among non-disease, without disease. Now diagnostic test studies, the word control does not exist. Many papers, many books, they write the word control. In diagnostic test study, the word control does not exist. Why? Because you are not comparing disease with non-disease. All you are doing is you want to find out how good my test performs in the disease and how well my test performs in non-disease. So it's not a basically a hypothesis testing situation. And so what is done in diagnostic test studies? You have group of people and these people are of two type. Some are disease, others are non-disease, and in both of them independently you administer your test, your candidate test, right? And the person is disease or non-disease or condition present or condition not present is as per the gold standard. What is gold standard? Gold standard is any test, gold standard is any test which is supposed to be superior than the candidate test. Gold standard always need not be the ultimate test. It need not be the tissue diagnosis. It can be any test which is superior than the candidate test. That is what is gold standard. So if you are evaluating X-ray, then ultrasound can be the gold standard. Whereas ultrasound is not 100% correct. There are other tests, radiological tests available which are better than ultrasound. But in this study, you can take ultrasound as your gold standard to evaluate X-ray. Right. So again, it depends what gold standard you are taking. It need not be the ultimate diagnosis. All studies are susceptible to bias. All studies are susceptible to bias. So are diagnostic test studies. So you have to make sure that you account for the bias, and these biases are minimized. There are three kinds of biases in diagnostic test study. One is a sampling bias. Sampling bias, basically it occurs because of selection of cases and non-cases. In what kind of population, what is your study population, right? That is what is basically will tell you about the sampling bias. Setting of a diagnostic test study should be similar to the one where this test has to be applied eventually. Right. So if you do a study in severe patients and find out what are the characteristics, then you have to apply this test in severe patients only. You can't apply in mild and moderate. Right. So there can be selection of cases and non-cases. Now again it depends what is the characteristics of population. Suppose if you take cases as from referral center where you have at the extreme top of the spectrum of disease, say for example All India Institute. In our institute, all the patients who come here, majority of them they have tried everywhere, and they could not get cured, so they have come here, right? So they are at the spectrum of at the highest spectrum of the disease. So in such case, if you apply a candidate test, you are not providing enough challenge to the test, right? So even if your test is inferior, not so strong, in very obvious cases it will say yes. So that's, you have not provided challenge to the test. Similarly, if you take non-cases who are healthy people, who are volunteers, they have no disease. So even a useless test will say 100% will not make any mistake, will say that none of them they have the disease. So that means you have not provided enough challenge to the test. So for diagnostic test studies, your cases and non-cases, there should not be any difference in terms of presentation. However, with reference to gold standard, cases are positive and non-cases are negative, but otherwise symptom wise there is absolutely no difference, right? So a case and a healthy volunteers, they will not present with the same symptoms, right? So that is what is basically selection bias. So therefore study sample should be representative of the target population. Another thing is it depends on the setting, like prevalence of disease. Suppose if you do a diagnostic test study at All India Institute, and if you take 100 patients, 100 suspected patients, out of 100 suspected patients you may find 50 are disease, 50 are non-disease, but in general population you will not find 50% prevalence of disease, right? Or maybe in other health facility you will not find 100% prevalence of the disease. So performance of the test varies from prevalence to prevalence. So that is what it is saying. Higher the prevalence would lead to overestimation of predictive values, therefore report predictive values at various prevalences. We will come to that again. So sampling bias. Another bias is measurement bias, non-blinding of raters. So when the candidate test is being administered, what is whether the person is diseased or non-diseased should not be known, should not. So basically the two should be independent. So that is what is non-blinding of raters. If the person knows that yes, this is disease, this person is diseased, then he is likely to be biased, right? So that is what is non-blinding of raters. Also many times if the condition is known, then borderline cases one may have tendency to push into cases or non-cases. So this may result into bias. So one has to take precautions with respect to sampling bias, with respect to measurement bias, and also like all other studies, all other studies, diagnostic test studies are also susceptible to publication bias, right? So if you do a study and if it is not conclusive or not very precise here, then you may have less chances of getting it published. So that is publication bias. So there are these are two biases: sampling bias, measurement bias, and reporting bias. Three types of biases. Another thing, like all research questions, all studies, chance is an issue. Same is with the diagnostic test studies. So if somebody is planning a study on diagnostic test, one would like to know as to how many cases I should take and how many non-cases I should take, right? So these are diagnostic test studies are cross-sectional studies, and in cross-sectional studies what we do is we find out the prevalence if my variable is categorical, right? So this is a cross-sectional study where outcome is categorical. Categorical means either test positive or test negative, right? Test positive or test negative. So we have to calculate sample size. We use the same formula 4pq upon d square here. Now suppose I am doing a diagnostic test study and I need to know how many cases I need and how many non-cases I need. You are doing the study, diagnostic test study, and you have come to me saying that I am doing a diagnostic test study, please tell me how many cases I require, how many non-cases I require. So I will ask you, what do you think would be what is the anticipated sensitivity of this test? So based on literature, based on past experience, suppose if you say I think 80%, so this test will be 80% correct in disease population. So sensitivity 80%. So you think 80% always on, maybe okay, plus minus 10, that is what is absolute precision, D. So P is anticipated sensitivity and D is 10. So you plug in these values and calculate the sample size. Suppose if you think that this calculation is too complicated, then you can go to the table. Go to the table, columns are basically prevalences, anticipated prevalences, and rows are absolute precision. So 80% is the prevalence and precision was 10%. So you go here 61. So you need to enroll 61 cases, and then you also need to know how many non-cases. So suppose if you say specificity is 90% and plus minus 10, so I will go to 90 and plus minus 10, so it will be 35. So 35 non-cases. So in diagnostic test studies, number of cases and non-cases will not be equal. It will be equal only when the anticipated sensitivity and specificity are the same and the absolute precision that you are taking also are the same. Otherwise it will not have the same in diagnostic test studies. So to evaluate a diagnostic test study, you are in a 2 by 2, you are always in a 2 by 2 table. If your candidate test gives measurement in qualitative, then you are in a 2 by 2 table, qualitative binary, then 2 by 2 table. It may so happen that your candidate test gives values in 4 categories. So then out of these 4 categories you have to collapse and make into 2 categories, right? You have to make into 2 categories. Suppose your test says 1 plus 2 plus 3 plus 4 plus. So then you may decide that 3 plus and 4 plus I would say is disease, and 1 plus and 2 plus I will say is no disease. So you have to draw a line. You have to draw a line and make it into 2 category, right? If your test is quantitative, then again you have to draw a line that above this value I will take it positive and below this I will take it as negative. So you are always in a 2 by 2 table. You are always in a 2 by 2 table. So here look at this disease present. So in this study, A plus C are the number of individuals who have the disease, B plus D are the number of individuals who do not have the disease, and in them you have independently administered the test, and you got A plus B individuals as test positive, C plus D test negative, and these are frequencies A, B, C, D. A are the ones who are disease positive and also test positive, that is true positive, right? The B is disease absent but test says positive, that's a mistake, that is false positive. C are disease present but your test has missed it, so test negative, that is false negative, right? So in B is what? In B your test has misdiagnosed. In C your test has missed diagnosis. So both are problems, both are errors, right? So you are in a 2 by 2 table, and then A is true positive, A is true positive, B is false positive, C is false negative, D is true negative. And these are the 2 characteristics of the test: sensitivity, specificity. Sensitivity means what proportion of disease have been identified as disease by the test. So A plus C are actually disease, and your test has picked up A of them. So A divided by A plus C into 100 will be sensitivity. Specificity would be how many of them are having no disease, B plus D, and in how many of them your test says no, that means D. So D upon B plus D. So these are the characteristics of the test. And then you have another 2 terms: positive predictive value, negative predictive value. Positive predictive value is if your test tells A plus B are positive, then out of this A plus B how many are actually positive. So A upon A plus B is predictive value, positive predictive value. Negative predictive value is your test tells C plus D are negative, then out of C plus D how many are actually negative, D are actually negative. So D upon C plus D will be the negative predictive value. And what will be the accuracy of the test? In how many of the individuals your test has done correct job, A and D. So A plus D divided by all of them, A plus D divided by A plus B plus C plus D, that is what is the accuracy. In what proportion of your study population your test has made correct decision, right? That is what is accuracy. Accuracy combines features of both sensitivity and specificity, right? But here you are not discriminating between false positive and false negative. Many situations where the penalty associated with false positive and false negative are not the same, then you don't take accuracy, because you may prefer a test to be more sensitive than specific, or in some situation a test more specific than sensitive, depending on the situation. right? So see this example, evaluating splenomegaly as a diagnostic test for malaria. So how many are 100 have malaria, 100 have no malaria, and your test was administered, test says 90 are malaria, and based on this 110 do not have malaria. So what is sensitivity? Sensitivity will be 80 upon 100. What is specificity? Specificity will be 90 upon 100. What is positive predictive value? How many are positive? 90 are positive. Of them, how many are actually positive? 80. So 80 upon 90 is the positive predictive value. What is negative predictive value? How many are negatives by the test? 110. Of them, how many are actually negative? 90. So 90 upon 110, that is negative predictive value. And what is the accuracy? 80 plus 90 divided by 200. That is what is the accuracy. So these are the things you calculate. So sensitivity, specificity are the characteristics of the test, and positive predictive value and negative predictive value are the performance of the test. So whenever we do a diagnostic test study, we calculate these 4 things, or maybe accuracy 5 things we calculate. Oh, this is what it is. Now, so what is sensitivity is defined as, we have already defined. Sensitivity is defined as true positive rate, and sensitivity is nothing but true positives divided by true positive plus false positive. The more sensitive a test is, the less likely it is to miss true disease, right? More sensitive a test is, less false negative it will have. False negatives are individuals with the disease whom your test has missed to identify as disease. So these are false negative, these are test false negatives. False negatives are, in these many your test has missed diagnosis, and false negativity rate would be 1 minus sensitivity. So if your test has 80% sensitivity, so false negativity rate would be 20%. Highly sensitive tests are useful for identifying diseases that are readily treatable, life threatening, or should not be missed. Every screening test should have high sensitivity. Why? Because screening tests are never applied in isolation. Screening tests are always followed by a more definitive test. So suppose, for example, I develop a test for neurodevelopmental disorders in children. Now in the population there are so many children, and how do you diagnose this? You need experts to diagnose, and we don't have so many pediatric neurologists to find out who are having neurodevelopmental disorder, right? So I may have a questionnaire, but this questionnaire should be highly sensitive. Let this be less specific. If this is highly sensitive, then it will not miss any case. If it is less specific, then it will pick up many of the false positives. Anyway, it doesn't matter, you bring all of them to hospital, and the expert will look at all these cases, and those false positives will be filtered out, right? So all screening tests should have high sensitivity. A sensitive tests are more, see, whenever you want to rule out a condition, sensitivity, pick up a test which has high sensitivity. That is what the term snout. Whenever you want to rule out a condition, so many tests will be available, you pick up the test which has got highest sensitivity. That is what is this one. What is specificity? Specificity is in the non-disease population. In non-disease population, in how many of them your test has been able to say is non-disease. So specificity is percentage of disease absence picked by the test in non-disease. And what is false positivity? 1 minus specificity. So if your test is 90% specific, false positivity rate will be 100 minus 90, which is 10%. Highly specific tests have great utility. Specific tests are useful when consequences for false positive results are serious. So say for example HIV, you will not pick up a test which has got poor specificity, because if it has got low specificity, there will be many false positives. So just imagine situation where you have used a less specific test, and based on that you tell a person that you are HIV patient, whereas actually he is not. So see the whatever the what kind of trauma or he will go through, what will happen to the family. So consequences are very high. So in such situation, use a specific test. Use basically a specific test. So these are serious emotional and financial consequences exist when a person is notified incorrectly of an HIV. In a disease free person, wrong notification is disastrous. Also, see, delaying diagnosis. So these are the problems. Accuracy, as I already explained to you, it encompasses both specificity and sensitivity. Accuracy is the proportion of all test results, positive and negative, that are correct, which is A plus C divided by A plus B plus C plus D. So just see this example are two methods, CT and X-ray, and the condition is fractured cervical spine, fracture in the cervical spine. CT scan is more sensitive and specific than X-ray. So any test which is accurate will always be superior. CT is more accurate, CT is more sensitive and more specific than X-ray for the diagnosis of fracture in cervical spine. Positive and negative predictive values. The predictive values, so far what we have discussed is sensitivity and specificity of a test. What is sensitivity? Saying yes as yes. Specificity is saying no as no. How often we say yes as yes is sensitivity, and how often we say no as no is specificity. And then we have false positivity rate, we have false negativity rate, and we have accuracy. That's what we have discussed. Now we are moving into something different. The predictive values are numbers that attempt to answer the relevant clinical question. Given this test result, what is the probability of disease? So there are two kinds of persons. One is researcher and second is the user of the test. So for a researcher, knowing sensitivity, knowing the characteristics of the test, that means sensitivity and specificity are of importance. He would like to know what is the sensitivity, specificity of the test. That means for him, disease condition is given, and he wants to know how well my test performs given the disease condition. Whereas for a clinician, disease condition is not given. What is given is the test result. So for him the question is reversed. He wants to know, given the test result, if a test result is positive, then what are the chances that the person has the disease in question? That is what is the predictive value. That is what is the performance value. So pre-test and post-test probabilities are also called a priori, a posterior probabilities, and respectively. Making a diagnosis is basically combining several things, and it is an iterative process. It is not in one go you always make a diagnosis. It's an iterative process. So if a patient comes to you in your OPD, you will take history, and by taking history you will arrive at some pre-test probability. Okay, I think the chances that this person has disease is whatever that you compute mentally, even though you don't write on your card, but mentally you compute that this is what is a probable diagnosis. But that probability is below your threshold level. See, every doctor, every health facility has his or her own threshold level for taking a decision. So if a patient comes to you, you take history, and by taking history, the probability that you assign, if it touches your threshold, you will take action. But suppose that probability is below your threshold, then you may go for you may order a test, go and get this test done, that test done, all those things you do, and then the person comes to your next OPD. Then what you do, whatever the pre-test probability that you have, that you arrived at by history taking, to that you combine the test result, and then you modify your probability and see now what is the probability. If that probability is less than your threshold, again you order the test, some other test you order, more sensitive and specific test you order. And this is an iterative process. It goes on and on till the probability is the threshold level. So the threshold level, again it depends on several things. Like for example, in our hospital, in All India Institute of Medical Sciences, our threshold is very high. And if you go to private hospital, thresholds are very low, because there they would like to take action, they would like to operate. Here they will not operate. Here they will go on, they will operate only when it is absolutely essential. But there outside, if you go, economy is also involved in this, finances are involved in this. So every setup has its own threshold. Making a diagnosis is an iterative process. So pre-test means before you ordered a test, what is the probability of a person having the disease, and post-test means you had pre-test probability, and to that you combine the test result, and then you modify the probability, that is post-test probability. This is what happens in diagnostic test. It is also known as priori and posterior probability. It is nothing but pre-test and post-test probability. So sensitivity and specificity, they are basically they are working in two sides of the coin: disease population sensitivity, non-disease population specificity. Likelihood ratio is the one which combines both together. So likelihood ratio, it combines both together. Also, see, not only test, there are various other conditions which will have their own chances of a person having the disease. So likelihood ratio, it can combine various sensitivities and specificities, and also it combines both sensitivity and specificity of the test. So likelihood ratio is always better. So we are going to discuss likelihood ratio now. But before we discuss likelihood ratio, please understand the difference between probability and odds. Probability and odds, because these will be used for calculation. So what is probability? Just think of this whole entire circle as 4, and this disease part is 1/4 and non-disease is 3/4, right? So this is 1 and this is 3, let's say this is 1 and this is 3. So if I ask you what is the probability of a person having the disease, so you will say 1/4, right? So probability of disease is 1/4. If I ask you what is the probability of a person not having the disease, so you will say 3/4. So probability of a person having the disease is 1/4, probability of person not having the disease is 3/4, and the ratio of these two probabilities is odds, because 4 and 4 gets cancelled. So what will be odds here? Odds will be 1/3, right? So see, the probability was 1/4 and the odds is 1/3. Which will be less? Probability will be less, because denominator is more here. So probability and odds, they are not the same, right? So if you know probability, you can always get odds. So probability is 1/4, so odds is 1/3. Suppose if probability is 2/5, probability is 2/5, so what will be odds? It will be 2/3, going by same. So this is what will be required. So take an example, if the probability is 0.3, so 0.3 means 0.3 divided by 1, which is 0.3 plus 0.7. So odds will be 0.3 upon 0.7. Odds numerator and denominator are disjoint. Denominator is not part of numerator, or say, so numerator is not part of denominator. In probability, numerator is part of denominator, right? So given one, you can always get the other one. Now suppose you are given probability 50%, what will be odds? 50% means 50/100. So this 100 will be 50 plus 50, so odds will be 50/50, that is 1. If the probability is 1/3, so what will be odds? It will be 1/1 plus 2, so that means 1/2, odds will be 2. 0.2 means 0.2 upon 1, that means 0.2 upon 0.2 plus 0.8, so odds will be 0.2 by 0.8, that is 1/4, 25%. Similarly, if the odds is 2/3, probability will be 2/5. So given one, you can always get the other one. This will be required. Why? The likelihood ratio, as per the definition, post-test odds. It is not post-test probability. Post-test odds is equal to pre-test odds into likelihood ratio. How did you get pre-test odds? Because you had pre-test probability. That you converted into odds. as I explained to you. So you have to convert pre-test probability into pre-test odds, and you have to have likelihood ratio. Likelihood ratio, if you have multiple tests, just multiply them, you will get the likelihood ratio. So we'll take an example of this and we do this, but we have not defined what is the generic formula for likelihood ratio. Generic formula is it is probability of test result in people with the disease. Probability of test result in people with the disease divided by probability of test result in people without disease. Now your test result can be positive or it can be negative. So then probability of a positive test result in people with the disease, that is nothing but sensitivity, and probability of positive test result in people without the disease, that is nothing but 1 minus specificity, and that is LR plus. So LR plus will be probability of positive test result among disease divided by probability of positive test result among non-disease, that is 1 minus specificity, that is LR plus. Similarly LR minus can be there. LR minus means probability of negative test result, probability of negative test result in disease, which is 1 minus sensitivity, and probability of negative test result in non-disease, that is specificity, right. So here we are talking about disease, non-disease. You can also talk about disease of interest and other diseases, right, like your disease of interest can be, let's say, sarcoidosis, and other diseases can be tuberculosis, right. So you may want to, because the two presentation is exactly same, so you may want to discriminate between the two, right, or let's say tuberculosis and no tuberculosis, right. So that is what it is. So you can have LR plus, you can have LR minus. This is what is explained here. LR plus is probability of positive test result in people with the disease, sensitivity, this is 1 minus specificity. LR minus is 1 minus sensitivity upon specificity, right. Diagrammatically it is shown here. So 80% by 40% will be your LR plus, and LR minus will be 20% upon 60%. Likelihood, what are the advantages of why we are not happy with sensitivity, specificity? Sensitivity and specificity are concepts that often waste information. Likelihood ratios best describes the value of a diagnostic test, because you are combining the feature of both sensitivity and specificity, and more importantly likelihood ratios are best for combination of tests, because no patient will come, because see, you make a diagnosis not based on single test, but you combine several test results and then you arrive at a diagnosis. So that's what is likelihood ratio test. Based on single test you don't make a diagnosis. Diagnosis is nothing but synthesis of inputs. So that's where easier to calculate for combination of independent tests, better estimates of probability when tests are not independent. So when working with likelihood ratios and other odds, pre-test probability is obtained easily by simply multiplying together all likelihood ratios. We will take an example. Hypertension prevalence. Now the question is, we want to identify whether the person has hypertension or not. Now this person comes from a population where prevalence is 27%. That means anyone coming from that population, pre-test probability is 27%, right. Or in the same way, suppose a person comes to you, you take history, and by taking history you assign a pre-test probability of 27%. This, I am 27% sure that this fellow has hypertension. That is pre-test probability. You have not ordered any test. Just by taking history you have arrived at this probability. So this is nothing but the prevalence of disease, or the pre-test probability, or prior probability, right. Now you have various tests available. You have three tests available: ECG, diastolic blood pressure, no family history, right. And for each of these tests they have their own sensitivity, specificity. That means they have their own LR plus and LR minus. So LR plus for ECG evidence is 5.79, diastolic blood pressure is this, no family history is 1.62, right. So now we have to find out what is the status of these three test results for this person, and accordingly we assign the probability. So the patient who has come has LVH by ECG, that means positive LR is 5.79. His diastolic blood pressure of this is basically is positive 108, that means LR plus he does not have any family history. If he had family history, then it would have been 1.62. Since he has negative family history, so 0.72. So 0.72. So what we do is 1 LR, second LR, third LR. With these we multiply pre-test probability, which is 27%, and then we do that. So we do that, we get when we get the post test, we get the likelihood ratios, combined likelihood ratios. We combine likelihood ratios if you multiply all the likelihood, but here we have to have pre-test odds. Now pre-test odds we don't have. What we have is pre-test probability. So this 27 pre-test probability we have to multiply, we have to convert into odds. So odds is probability upon 1 minus probability, so it is 0.37. So this is what is pre-test odds. To this pre-test odds 0.37, we multiply these three likelihood ratios. So what we get is the post-test odds, because we had defined post-test odds is equal to pre-test odd into individual likelihood ratios. We get 10.69. This is post-test odds. Now this post-test odds we have to convert into probability. So probability is 0.914, right? So 0.914 is 91% or 90%. So 90% chances that this person has hypertension. When we had not used any test, then the probability was 27%, but with test now the person has become wiser. Now the probability of this person having hypertension is 91%. So that is how you combine several tests. Every test will have sensitivity, specificity, so likelihood ratios, and will have pre-test probability. So what you have to do is you have to calculate post-test odds. Post-test odds is equal to pre-test odds into multiplication of likelihood ratios. Multiplication of likelihood ratios. So you get post-test odds, convert into pre-test probability. Now we have three tests here. Suppose we do not have result for one of the tests. So then for that you consider likelihood ratio as 1, right? So consider as 1 and then calculate post-test odds. Now for this you convert into pre-test probability, and accordingly you do that. So this was the situation where your candidate test was categorical. But what happens when your candidate test is quantitative? If your candidate test is quantitative and we have this kind of situation that all disease population lowest value, and for non-disease highest value there is a gap. So if we take this as a cutoff, then we will have 100% sensitivity and specificity, but there is no quantitative test which has this kind of clear dichotomization. We will always have overlap. So we have to take a decision. If I take this point as the cutoff and say anyone, so this is disease population, this is non-disease population. So if I take this as cutoff and say anyone above this is disease, then these fellows who are normal, to them I am labeling them as positive. These are false positive. And what I am saying is all individuals below this are non-disease. So even disease, so to all of them I am saying false negative, right? So shifting this line, this vertical line, will change your false positivity and false negativity. That means sensitivity and specificity. So in case of quantitative, we have to decide where do we draw this vertical line. And that is what we have to do, and that we do by using ROC curve. So here suppose if I take this as the cutoff, so what will be the true positivity rate? That means sensitivity would be, this is the true positive divided by true positive plus false negative. That is what is true positivity, that is sensitivity. What will be false positivity rate? Will be this these dots divided by the whole thing, that is 1 minus specificity, right? So you have to change this to find out what should be appropriate cutoff, and that is done using receiver operating characteristics curve. ROC curve is a method of graphically demonstrating the relationship between sensitivity and specificity. So ROC curve plots positive rate, sensitivity and false positivity rate. So sensitivity on y axis and false positivity rate on the x axis. let's go to this. So this each on this line each dot represents pair of sensitivity and specificity. We would like that cutoff which gives 100% sensitivity and 100% specificity. So 100% specificity means 0% 1 minus specificity. So we should be here, right? What is this diagonal line? Diagonal line is basically 45% angle. It is almost like tossing of a coin. So any candidate test, the line should be above this line. If for any candidate test, if this line is on this diagonal, that means that test is as good as tossing of a coin, right? So area we need to calculate. Area below this is 50%, above this is 50%. So any test has to have area more than 50%. This is what is your unexplained part, right? So we draw ROC curve and then we have to find out which point we take. So we have to take a point which is as close to the diagonal as possible, right? And then see, suppose this is the point which is closest to the diagonal, then from this I draw a line here, and from this I draw a line here, and find out what is sensitivity and what is specificity for that pair. That is what is being shown here. So what are the steps in planning a study on diagnostic test? First of all, you have to say, is there any need for diagnostic test or not? Describe how you are going to enroll your subjects, what is the gold standard, and you also have to say that how will you administer your candidate test, how will you ensure blinding. Blinding means the person should not know the status of this. You need to calculate sample size, calculate confidence interval, and you should have report predictive values, and also you have to report predictive value for various levels of prevalences. That is what is done, and these are some of the references for diagnostic tests. If you are interested, you can read these references, and I have made the slides from these references only, so you can go through that. So questions देखो जरा भाई, questions कहाँ देखें? इसमें देखो कोई क्वेश्चन है क्या?
पूछा नहीं सर किसी ने, ये लोग हैं सर जितने ना,
पूछा नहीं है?
नहीं सर.
No question. So okay, so there are no questions, so we stop, and let me take this opportunity to wish you, your family, your friends a very happy and very very safe Diwali. Don't fire crackers. All the best. Thank you. डिलीट कर दो ये. हो गया ना? इसकी रिकॉर्डिंग होती है क्या? रिकॉर्डिंग होती है, रिकॉर्डिंग मिल सकती है.